I'm going to explain genital herpes in pregnant women, clearly, calmly, and clinically. Genital herpes is caused by the herpes simplex virus, usually HSV2, sometimes HSV1. It spreads through skin-to-skin contact, oral sex, vaginal sex, anal sex. You can pass it even without visible sores because of viral shedding. Two scenarios matter in pregnancy. A first-ever infection, called primary, versus a recurrence. Primary infections late in pregnancy carry the highest risk to the newborn. Recurrences are common but usually lower risk. Symptoms can include clusters of painful blisters, ulcers on the vulva, ulcers on the vagina, ulcers on the cervix, ulcers on the anus, ulcers on nearby skin, burning, tingling, fever, swollen lymph nodes. Some people have no symptoms at all. Picture a 3D anatomy view: external vulva, vaginal canal, cervix, nearby nerves. After first contact, the virus travels along sensory nerves to ganglia, where it becomes latent. Later, it can reactivate, move back down the nerve, and cause lesions or silent shedding. During pregnancy, immune shifts and increased blood flow can change how outbreaks feel. Most recurrences are manageable. The main concern is viral shedding at delivery, which can expose the baby during a vaginal birth. Neonatal herpes is rare but serious. Risk is highest, up to 30–50%, if you acquire herpes near the time of delivery. With known recurrent herpes, the risk at delivery is much lower, about 1% or less, especially with suppressive medication. Diagnosis uses a swab PCR from a fresh lesion. Blood tests for HSV1 and HSV2 antibodies can show past exposure, but they're less useful without symptoms. Always pair results with a clinician's guidance. Safe antiviral options include acyclovir, valacyclovir. For a first episode, treatment reduces symptoms and shedding. From about 36 weeks, many clinicians start daily suppressive therapy to reduce outbreaks at birth. If you have active genital sores at labor, a C-section is usually recommended. If you have prodrome, tingling, or burning at labor, a C-section is usually recommended. If there are no lesions and you've been on suppressive therapy, vaginal delivery is often appropriate. Your obstetric team will guide the plan. Use condoms, dental dams, avoid sex during outbreaks. Consider suppressive therapy if one partner is negative. Avoid new sexual partners late in pregnancy to limit first-time infection risk. Breastfeeding is generally safe unless there are herpes lesions on the breast. Hand hygiene and covering any lesions matter.